Hello, everybody. It's Sahil Parikh from Columbia University of New York. I'm really delighted to be joined by my friends and colleagues, Dr. Bill Gray from Lankino in near Philadelphia in Pennsylvania, and Eric Secemsky from the Beth Israel in Boston. We're here for a special episode of the Journal of SCAI Endovascular Late-Breaking Clinical Trials. We're going to be talking today about Disrupt PAD3, which will be a late-breaking clinical trial presented by Dr. Gray at the SCAI Scientific Sessions in 2022. And we're really excited to hear about the manuscript, which will be simultaneously published with the presentation, and also talk about its implications for the field. So without further ado, Bill, why don't you walk us through the highlights of the paper, and then we'll talk some more about it.
Thanks, Sahil. I really appreciate the opportunity to walk through these data sets. I'm going to share my screen here. This is a shortened version of the longer presentation that I'll give actually at the meeting. And obviously the manuscript will be much more detailed, but this will give the highlights of the outcomes of the trial. So the trial design was an interesting one, both in concept and population. The primary objective of the trial was to assess the safety and effectiveness of IVL versus PTA plus DCB to treat moderately and severely calcified femoral popliteal arteries. And you're going to see in a moment that they were mostly severely calcified. And the statistics were really around the primary and secondary powered endpoints, which I'll show you here in a second. There were 306 patients randomized between IVL and PTA. And depending on the results of that initial randomized assignment, patients received a DCB or a DCB plus minus a stent if the residual stenosis was greater than 30%, or there's a flow limiting dissection, or both. The procedural success plus 30-day follow-up was the primary endpoint. And then the secondary endpoint was the 1-year primary patency. And we have data on 2-year follow-up, although somewhat incomplete. We wanted to include it in this paper because we thought it was relevant. As I mentioned before, the primary endpoint is procedural success is defined by residual stenosis of less than or equal to 30% by angiographic core lab, without a flow limiting dissection, grade D or greater, after balloon therapy and prior to DCB plus or minus stenting. The secondary effectiveness endpoint, which is the topic of this paper and presentation, is the primary patency at 1 year, defined as freedom from clinically driven TLR and freedom from restenosis as determined by Doppler ultrasound or angiogram greater than or equal to 50%. Noteworthy in this trial is that any stent that was placed at the time of the original intervention is considered a primary loss of patency for purposes of the definition of this trial. So if we look at the outcomes, which have already been reported and published, Gunnar Tepe, my co-principal investigator, was a principal author there. We know that the lesion length was about 10 centimeters in both arms. And the primary endpoint of procedural success was achieved more frequently in the IVL group as compared to the PTA group, about 2/3 of the time versus about half the time. Major dissection was noted for type C or D in about 10% and 7% respectively of the PTA group, as compared to only about 1 or 2% in the IVL group, also statistically significant. And stent placement was about 4 times more frequent in the PTA group as compared to IVL for either dissection or residual stenosis greater than 30%. Now, the principal findings in this paper is the primary patency at 1 year. And if we look at that, we see an advantage of IVL over PTA by about 12%. And that's driven largely by the stent implantation at procedural day 0. And you can see that here in the first row on the right. If you look at the freedom from clinically driven TLR and freedom from binary restenosis from the time of procedure forward, there really is no difference between IVL and PTA in the patency rates at 1 year. If we look at the patency rates at 2 years, and again, the data are somewhat incomplete, but again, we thought it was important to include this kind of intermediate length of follow-up. We see that there's actually a maintenance of patency over the course of the next 2 years. Some people read a divergence in the lines here. I think that they're more or less parallel. And actually, at 2 years for the IVL group, an excellent patency in a highly calcified lesion set of about 75%, meaning that both freedom from binary restenosis and clinically driven TLR was absent in 3 out of 4 patients in a highly calcified lesion set. So the conclusions of this study, the extension of the original trial, is that the Disrupt PAD3 randomized control trial, again, provides the largest long-term level 1 evidence to guide endovascular therapy of heavily calcified femoral popliteal arteries. The primary and secondary endpoints were achieved with superior procedural success and primary patency at 1 year with IVL. The low rates of clinically driven TLR and restenosis in both arms are consistent with results across other IVL trials. Interestingly, the PTA results are actually an outlier compared to most PTA trials that came before, even with DCB. And I think it's a point that we can talk about in the discussion to follow this. And then lastly, Disrupt PAD randomized control trial demonstrated consistent safety and effectiveness of IVL treatment that facilitates a durable approach to patients with heavily calcified femoral popliteal lesions with significant reduction in bailout stenting, which preserves treatment options going forward in claudicants with severe calcification in the femoral popliteal region.
Bill, thank you. So it's actually incredible that we are now seeing really level 1 evidence in a randomized fashion in an extremely calcified lesion subset. Bill, as the principal investigator, what was your feeling going into the trial about enrolling this lesion subset that had, at least until now, been largely excluded from every prior trial?
Well, I think that there were some earlier PAD trials that actually gave us some insight as to how we would do acutely on the procedural basis. And as you put together a trial, everybody in this call knows, you try to use the bits of information you understand, extend that knowledge to the best you can, and then try to do something exploratory that will help advance the field. So the procedural element of this was really the nut of it. And I think we had pretty good insight from Disrupt PAD 1 and 2 that we could probably dominate PTA as compared to IVL. We did talk about other therapies. Calcium and PTA are not the only therapy available. Atherectomy would be another one, and so on. But we felt that got a little complicated. And frankly, PTA is still the standard of care in terms of comparators for balloon-to-balloon therapy, which is what this is. Then I think we extended the knowledge base. Remember, it sounds easy to talk about now. You should have had a 1-year endpoint. Well, nobody knew what the 1-year endpoint for calcified lesions was going to be. No one ever studied them before. There have been some small non-randomized single center studies like Finelli's trial, looking at calcification, very exquisitely done with IVUS and so on. But the knowledge base there then, and I would submit even now, is still missing. And this is a little brick in the wall of that knowledge base, but I don't think we even have the questions after a randomized controlled trial of calcified lesions. So hopefully that gives you some insight as to how we kind of put this trial together.
Right. And so Eric, you obviously have a breadth and depth in this field, particularly when it comes to the clinical trial data that have emerged these last 5 years. How do you put in context what we just heard with respect to the existing tools in the toolbox for the treatment of fempop lesions?
First, to Bill, for you and the entire investigatory team, congratulations. It absolutely is much needed data in the space. We lack data. Anything in plaque modification with the randomized trial data, as we know, is sparse. And this is now going to be one of the largest randomized trials that compare plaque modification prior to DCB. So, really thrilled to have these data. I'm going to make 2 comments here, and then maybe we could break them down. The first is, what did we accomplish in the study? And like you said, Bill, there are acute needs of this study, and then there were some, aspirational goals. One thing that always is complicated in PTA trials is what to do with bailout stenting. And so, I'm going to go back to that in a minute, because I do think it's worth mentioning. I know, Bill, you've talked a lot about this, but the other thing that's really impressive in this trial, again, is just a reminder of what DCBs do in calcified lesions still. And we made a comment, as you put in the conclusion slide, that, the PTA arm was, performed actually pretty well. And, it's impressive. Obviously, it was impacted by the higher rate of stent utilization. It's still quite impressive that we're getting better numbers at 2 years for complex fem pop lesions. So maybe Bill, I'll start there. Just how the field emerged as this study has gone on, and also what you guys included in the study, which is DCB in both arms. And then maybe I could ask you some more pointed questions about the stent outcomes.
Yeah, I mean, if we're talking about trying to figure out and assimilate the PTA arm results, I think it's an outlier. I mean, if you look at all the PTA outcomes, even for DCB and PTA in non-calcified lesions, at 2 years having with a 10 centimeter lesion set, 2 years having about 60 or so percent patency is not really, we don't see a lot of that. So my sense is that a couple of things probably happened here. One is we had the best operators in the world. And I sound like, a former president, but we really did have the best operators in the world. And we told them, go make this lesion the best you can make it with the balloon therapy. So we asked them to vessel prep, even though we didn't use those terms. And they went out and they tried to make the best vessel they could. And they only stented when they needed to. In spite of that, and I know you're going to get to stenting here in a minute, 1 out of 5 patients roughly needed a stent versus about 1 out of 20 patients needing a stent in the IVL arm. And that's a material difference in terms of what the stent confounding will be for PTA and longer term outcomes. But again, I come back to it. If you were to plot this on a graph of all the studies that have come before, PTA or DCB plus PTA, even without calcification, this is an outlier. And I would submit that anybody who tries to compare these data will fail at the first attempt, because there's no data on calcified lesions like this.
Yeah. But going back to the stent data, I mean, I think it was appropriate how the study was designed, that you were penalized for a bailout stent by becoming loss of patency. And so, again, I think for me, especially when you presented the 30-day outcomes and published, it was really an important study because it showed you we really still feel that scaffold-free approach for most SFA pop lesions is the appropriate strategy, and how to do that safely is with IVL in that trial. We had much less need for ballot stenting, much less high-grade dissection. When you start to get into longer-term outcomes, it's obviously really hard to look at. And so, if you break down the data, the patency rates at 1 year and even 2 years are probably driven, if not fully driven, by the loss of patency with getting more stents in the PTA arm. And once you take that population out, the CDTLR rates are equivocal between strategies. So in your head, I mean, in your mind, is this the right way to deal with ballot stenting, and does it matter? I mean, I think it's important for SFA pop to think about scaffold free still. So even if this is the endpoint where you avoided a stent, does it matter that your patency is driven by that?
Yeah, I think, well, first of all, just to be clear, those patients weren't taken out of the analysis. They were included in the longer term analysis. All we did with them was look at the ongoing CDTLR and the ongoing primary patency. And if you do that, absent the loss of patency at day 1 or day 0, you're right. You don't see any big differences between the two of them. Look, I think it boils down for me to maintaining options. As we all know, when you get into a stent restenosis, it gets to be pretty sticky. Now, this trial, again, even with stents and DCB, was an outlier. If you look at the global registry for impact, we didn't see this kind of patency at 1 or 2 years. So I don't know how to really put this in context, other than to say, I'm still wanting to avoid a stent. I still want to do the most effective, most efficient, and safest procedure. And if we look at the various options that are available for calcified lesions, it's PTA, it's atherectomy of multiple varieties, laser, directional, rotational, and then there's IVL. And to me, from a safety and efficiency standpoint, IVL wins every day on that, and especially if I want to avoid stent implantation, which, by the way, atherectomy does a pretty good job of too, but with a lot more, upfront cost in terms of the embolic protection, emboli, perforation, and so other. Both effectiveness and safety endpoints, I think, are different than they are for IVL, which is incredibly safe.
Yeah. I mean, that's really important, because we saw in like Vivo Reality, there was still a reasonable amount of embolization and, need for EPD and whatnot, and you're avoiding that here. So it's great. I'm going to make one last comment. I'm going to throw back to you, Sahil, but, the one question that I think most people want to know the answer to, but not sure we got the answer from this study yet, is, does IVL improve drug uptake? You know, we talk a lot about plaque modification before DCB as being an effective mechanism. We can't fully understand that from this study. Does it deserve another smaller study or sub-study or future investigation? Do we have enough here that really we should be doing plaque modification before DCB treatment, in particular for moderate to heavily calcified lesions? What's your take on that?
Yeah, my sense is that vessel prep probably makes a difference in just about every therapeutic that we offer. I think a lot of the superior data was probably related, the very good superior data was probably related to aggressive vessel prep in that population, with the knowledge that you could stent whatever happened after your aggressive vessel prep. So do I think it matters? Yeah, I think it does. And I think more than the messaging around calcification and DCB uptake, which I always thought was a simplistic way of looking at the data that were kind of out there, Finelli's data and others, you know, a physical barrier, well, maybe, but I don't know if that's real or true, you know, not. I think more importantly is that to me, vessel prep emerges as a very important component of what we should be doing and emphasizing in all the procedures we do. And again, then it comes down to, well, how do you want to prep the vessel? You want to use IVL, you want to use PTA. If you don't care about putting stents in, well, it probably doesn't matter what you do. If you care about putting stents in, then IVL is probably the best first choice.
Great
So
comment.
Bill, so Bill, that's exactly the point, right? As a consumer of the manuscript, if you were to come up with a take-home message, you know, the so-called one-line take-home message, what do you think it should be for the average everyday operator who's reading these data at home and trying to figure out how to apply the technology?
Yeah, I think what I would say is for severely calcified femoral popliteal lesions, that the most effective, most efficient, and safest way of managing those lesions that leaves least stent implantation and the most options going forward is IVL. You know, it sounds like an advertisement for IVL, but I can't look at the data and think of anything else.
Well, and it's also certainly a testament to you and the trialists who were able to achieve the powered endpoints, both primary and secondary, whereas many of the others are just essentially registries where they've neither had the power nor the ability or the wherewithal to stick with the trial to get over the goal line. So I think that's a testament to you and all the investigators who participated.
Yeah, can I just make one comment on that, Sahil, which is that this trial started several years ago, before paclitaxel and before COVID. And after, by the way, clearance of the device by the FDA, the company, Shockwave, did not have to do this trial. But they did it, I think, to advance the science and to show that their device was really meaningful in the larger management of calcification. It was a bear to get through. There were generator changes, there was COVID, there was paclitaxel. But a credit to both Shockwave for seeing it through and for all the investigators for the continued, not just enrollment, but important follow-up that got this trial, the data that we can now talk about.
Very important study, and we're really happy to have it, Bill.
I agree.
Yeah, it's important for the field, and we're certainly excited to have it at JSCAI. I also think it starts to help us come up with a strategy for the treatment of FemPop disease that is evidence-based. I think that's something we've all been yearning for over the last decade, as we have myriad tools in the toolbox, but now we really have some evidence behind it. So with that, I'm going to welcome everybody to read the manuscript, which will be published simultaneously at JSCAI. And we want everybody to stay tuned for future updates with more late-breaking clinical science and for more exciting innovations in endovascular therapy. I want to thank our panelists, Bill Gray, co-principal investigator of DisruptPAD 3, for presenting the data, and for Eric Secemsky from Boston for applying his expertise as an operator and an investigator. And we look forward to seeing you guys next time. Thanks for joining us at JSCAI.
Thanks, guys.
Thank you.